Welcome to today's webinar. This is part of the year-long medical webinar series on aging and longevity, an initiative of the Museum of Physiology in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Museum of Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPT units for N. Welcome to today's webinar. This is part of the year-long medical webinar series on aging and longevity. Welcome to today's webinar. This is part of the year-long medical webinar series. To1.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Aging Webinars, and YouTube Live at Aging Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval. The webinar will begin in 5 minutes. Please stand by. Welcome to today's webinar. This is part of the year-long medical webinar series on aging and longevity, an initiative of the Museum of Physiology in celebration of its 85th year, in cooperation with the UP College of Medicine, the UP Medical Foundation, and the Museum of Foundation. The beneficiary for this project is the National Institutes of Health Institute on Aging. This webinar series runs every second and last Friday from January to November 2019 and delivers interactive medical lectures by prominent specialists here and abroad on common medical conditions in the geriatric population. The webinars are free and open to all physicians, healthcare professionals, and medical and allied medical students. CPD units for MDs, nurses, and pharmacists will be provided. Registration is free. If you have pre-registered, you only need to sign in for attendance check. Otherwise, please register on-site. Just click on the links for today's webinar at the bottom of the UPM livestream window or in the description box of FB Live or YouTube Live. This is an important step that you need to do to have your attendance recorded and to receive the link to the evaluation form. Once you sign in for attendance, the post-webinar confirmation email will be sent within 12 to 24 hours and not immediately. To ensure that you receive your certificates in your inbox, please be reminded of the following. Make sure that your details are complete and spelled correctly, especially your names and registered email addresses. Please do not abbreviate. Example, yahoo.com into y.com. Ensure that your email inbox is not full and add these email addresses flashed on your screen to your contacts. Check your spam folder, and if our emails landed there, mark them as not spam. We are now using UP Manila Livestream, FB Live at Asian Webinars, and YouTube Live at Asian Webinars channel. If you are encountering problems in internet connectivity, kindly refresh the page. For UP Manila Livestream, kindly turn up the volume using the audio icon. For other problems, please refer to the downloadable guide at the bottom of the livestream window. The webinar lecture will run for 20 to 30 minutes, followed by a question and answer portion. Ask questions or comment by typing into the UP Manila Livestream Q&A box on the right lower corner of your screen, or type into the comments box in FB Live or YouTube Live. A link to an online evaluation form will be sent to your registered email addresses 2 days after the confirmation email is sent after the webinar. Please answer the online evaluation form to receive your certificate in your registered email inbox around 2 to 4 weeks after the webinar, depending on the number of participants and CPD unit approval.
Good morning, everyone. I am Ms. Layaan Zamora, Mu Sigma Phi Sorority Batch 2014, speaking on behalf of the Aging and Longevity webinar team of the Mu Sigma Phi Sorority. You are watching a video of the webinar pre-recorded from the UP Manila Museum of History of Ideas at Padre Jaura, Manila. So for today's webinar, we are privileged to have a distinguished alumna of the UP College of Medicine, Class 1979. She finished her residency in internal medicine in UP-PGH in 1983 and her fellowship in pulmonary medicine in the section of pulmonary medicine, Department of Medicine at the UP-PGH in 1984. Currently, she teaches in the UP College of Medicine and is an active consultant in UP-PGH, East Avenue Medical Center, and the St. Luke's Medical Center. She serves as the director of the training division of the Philippine Tuberculosis Society Quezon Institute. Her past leadership positions include being the past president of the Philippine College of Chest Physicians, past chair of the Department of Medicine in East Avenue Medical Center, and past chair of the Ethics Committee of the Philippine College of Physicians. Ladies and gentlemen, we are proud and honored to welcome Dr. Bella Shasoko, Mu Sigma Phi Sorority Batch 1979.
So, good morning. It is truly a privilege to be here and to share with you my knowledge in lung cancer, and more particularly for lung cancer in the elderly population. So let's get going. Okay. First, I have to tell you of my disclosures, none of which have any direct bearing to lung cancer. My objectives for this particular session to recognize why treatment decisions and prognosis differ in the elderly patients with lung cancer. I want to focus on evidence-based guidelines, and particularly these are the American College of Physicians third edition or 2013 version of the management and diagnosis of lung cancer that are pertinent to the care of elderly cancer patients. I will eventually outline present treatment options for the care of the elderly with lung cancer, and then also identify some tools that may help prognosticate the outcome of treatment of lung cancer in the elderly patients. All right, just to get into perspective, these are the figures of 2014, and there are 8.2 million cancer-related deaths worldwide. Of the 14.9 million new cancer cases diagnosed, most of them are occurred in Africa, Asia, and Central and South America. But if you will look at the graph, in 2017, 13.2% of all lung cancer cases, of all new cancer cases were of lung cancer, and 25.9% of all deaths from cancer were pulmonary in origin. Okay? For women, breast cancer was the leading cause of disability-adjusted life years globally. However, mortality from lung cancer far out surpassed that. And this could be due partly to the lack of funding or to the support given to lung cancer as versus breast cancer studies. Okay? Lung cancer is basically a disease of the aging population, mainly occurring in ages more than 65, and with the average age of diagnosis approximately 70 to 75 years old. You all know that there are two types, small cell and non-small cell, and together they comprise the lung cancer that is the second most common cancer in both men and women. In the Philippines in 2017, lung cancer was ranked 72nd worldwide with 11,000 deaths. So you can see that lung cancer is an equal opportunity condition. Okay. In the Philippines, adenocarcinoma, the prevalence in both males and females are increasing. And in fact, a recent study showed that in the Philippines, despite the prevalence going down worldwide, in the Philippines, statistics remain the same. Adenocarcinoma is currently the common histology of non-small cell carcinoma. In the Philippines, previously, squamous cell carcinoma was more common, and this was more common among males. All right. Having that background on lung cancer and its numbers, let's go to some of the recommendations of the American College of Chest Physicians that came out in 2013. By far, cigarette smoking is the most predominant cause of lung cancer. There are other causes like environmental exposure or radon exposure, but just to debunk some of the beliefs as to what we can do, what we can take to prevent lung cancer. This is a presentation of the list that was proposed that some people saying if we do take some of these products, lung cancer prevalence might decrease. Just to say unequivocally, none of these have been proven, and therefore none of these have been shown to really prevent the occurrence of lung cancer. However, granting that cigarette smoking remains a predominant risk factor, there are some measures that we can take. Of course, the number one measure is to stop smoking. However, for those who find it difficult to stop smoking, counseling pharmacotherapy is recommended for current smokers. There is a recommendation for low-dose CT screening for a select population, which I'll discuss later. Counseling and pharmacotherapy has also been recommended for current smokers with demonstrated smoking-related pulmonary disease and pertaining, for example, to COPD. Lung cancer patients undergoing radiotherapy can also benefit from counseling and pharmacotherapy. The advice to stop smoking may come with several pharmacotherapeutic measures, especially for lung cancer patients who are about to undergo surgery. If some of these interventions, or one of these interventions, is the use of the drug bupropion. If this drug is either contraindicated or refused, then cessation counseling alone during the perioperative period may be initiated. So, and also bupropion is an ideal drug for lung cancer patients with depressive symptoms. Okay, I mentioned low-dose CT screening for many of these patients to detect if this recommendation is not for everybody. The recommendation is for this particular population, for smokers and former smokers, for those who are aged 55 to 74, and for those who have smoked 35 years or more and either continue to smoke or have quit within the past 15 years. The recommendation to have these patients screened by low-dose CT scan is quite strong. Low-dose CT scan, however, is not recommended. It is not recommended for populations out of those. And in fact, for those who may be interested to know, to screen with a chest radiograph or a chest X-ray is also not recommended and has not been shown to have a very good take-up rate. The screening for lung cancer with sputum cytology also has not been shown to pick up lung cancer early in the course. And of course, stopping smoking is the best measure. Okay, so in terms of prevalence and characteristics of the different cell types of lung cancer, the most prevalent, comprising approximately 50%, is adenocarcinoma. This is the most common cell type found in non-smokers, and yes, even non-smokers can develop lung cancer. This type of lung cancer develops in the periphery of the lung, and they spread or metastasize when the tumor is relatively low, and there are some markers like EGFR whose mutations are possibly seen with the different variants. Now, since there is a lack of awareness that lung cancer can occur in non-smokers and that this type of carcinoma, that is adenocarcinoma, develops in the periphery of the lung, this type of cancer, which is the majority of the lung cancers, is often diagnosed late or in the less treatable phase of the disease, and therefore may creep up very silently in patients. The second most common type of lung cancer is squamous cell carcinoma. This is a central developing lesion. In the past, it was the most common, but the prevalence is now declining in favor, if you want to call it that, of adenocarcinoma. It is highly correlated with smoking, and it is slow to metastasize, often metastasizing to the local node. So if ever anyone is to get lung cancer, hopefully not, but should they, then this is, if you want to call it, the best type to get. The third most frequent is the small cell carcinoma. This is a very separated group of lung cancers. It is very aggressive, very rapidly growing tumors. And the fourth type is large cell carcinoma. Again, a peripheral type of carcinoma that metastasizes when the tumor is still relatively small. Mutations involving this cell type are also common. Okay. Treatment for lung cancer is based on the stage or extent of the disease. In sick or elderly patients, there are so many comorbidities that are possible and have to be taken into account when deciding on a treatment approach in these patients. Okay. At diagnosis, patients with non-small cell lung cancer can be divided into three groups. 30% of the cases are diagnosed in an early disease stage, and these tumors, should they develop and be detected at this stage, are surgically resectable. 20% of patients are either locally or regionally advanced tumors. These patients can be treated with a combination of chemotherapy and radiotherapy. Unfortunately, again, a large number of patients, nearly half of the patients with lung cancer, are detected when they already have distant metastasis. The only treatments available for these patients are chemotherapy or radiation therapy for palliation of symptoms. This was before. We do not consider cure in patients with distant metastasis, but we can consider a certain degree of control or disease control in that population. Okay. At each step in the diagnosis or the course or management of lung cancer, there are certain important decisions to be made. Biomarkers are possible in various stages like risk assessment, in the diagnosis, in the staging, and even in the treatment of these patients to monitor the course of the condition. And when we mention biomarkers, of course, you know that these are the measurable products of tumors that can assist in the diagnosis, prognosis, or prediction of outcomes. Now, for each stage, once biomarkers are possibly identified, these can lead to one of these, as you can see, treatment decisions. And then this is now determined to be a personalized approach to lung cancer. Okay. Now let's focus, having discussed in passing all of those, let's discuss the elderly with lung cancer. Senior patients have now been, they're not all lumped as senior. There is the young senior. These are the ages, young old senior. These are from ages 65 to 75. There is the old senior, the 76 to 85 years old, and the oldest of the old, who have been chronologically gifted to be above 85 years old. In fact, most of the lung cancer cases are diagnosed approximately at 75 years old, and treating the senior adults with cancer has specific, unique challenges. There are physiologic changes associated with aging that lead to a decline in organ function and impact outcomes with treatment. Health status and functional reserve may also vary significantly in these individuals. And, chronologic age alone is an unreliable predictor of the risk of treatment in these patients. So in these individuals, there is a saying that 50 is the new 30 and 70 is the new 50. Physiologic age may not always correlate with the functional, chronologic age may not always correlate with the functional age of these patients. The numbers that you will see, 1 in 15 chance of developing lung cancer in males and 1 in 17 chance of developing lung cancer in females, take into account both smokers and non-smokers. Of course, the risk in smokers is higher, while those for non-smokers is lower. Still in all, as we mentioned previously, lung cancer is not related to age, and there has not been found to be any correlation between the occurrence of lung cancer and ages of the patient. It's an equal opportunity condition, and variations reflect differences in baseline health, comorbidity, and genetics. Okay, lung cancer is the most common cause of cancer death, as we said, in men and women in Western countries. The 5-year survival rate of lung cancer is 15%, which is among the lowest of all cancers. The high mortality from lung cancer may be due to the late stage of diagnosis, but may also be due to the lack of effectivity of treatment, even for patients diagnosed with stage 1 lung cancer. If, but you would think, and as mentioned way 2 decades, 3 decades ago, that the slower growing and more indolent bronchial cancers are more common in older people, then the screening of this population may be more effective than that of the younger population, in which the aggressive disease seems to be more common. There is more time and more opportunity to treat and diagnose and screen the older population. So now we have a conjunction of two situations: the increased life expectancy these days and the increased incidence of cancer with age. As mentioned previously, 65 to 75 years of age, at least one-third of the patients are diagnosed at greater than 70. This is somewhat dependent whether only clinical or histologic diagnosis is considered. In the past and perhaps in the present in the country, not many people or not that many people pursue aggressive treatment for one reason or another, one of which could be economic. And also dependent on the health policies of the countries involved for where the data is obtained. So the upper age limit as an exclusion in phase 3 studies, these are the clinical trials. Many clinical trials include certain ages of patients, and unfortunately, they also exclude patients with conditions, comorbidity, functional status in the population which is most affected by cancer. So the trials may disproportionately underrepresent older adults. It suggested that a new policy, which was in the United States put into effect and sponsored by the National Institute of Health, it started in January 2019, just early part of this year, that recommended that patients and clinical trials, that patients be involved in clinical trials regardless of age. In other words, if an individual is 85 years old, then the study should not exclude individuals with comorbidities, because realistically, many of the 85-year-olds and in that area do have comorbidities. And so the exclusion of those patients, the exclusion of those patients from those studies might influence the outcome of those studies. This act was called the 21st Century Care Act. As we mentioned, many of these studies may exclude the population that is most affected. For example, because the patients are already on other drugs. And seriously, how many people who are more than 60 years old are not on other drugs? There are very stringent inclusion and exclusion criteria to those studies. Some of the patients may have difficult access to the specialized institutions where the studies are being conducted. So really, the studies on lung cancer and lung cancer treatment may misrepresent the actual figures for these patients. So, saying that, we affirm that screening for lung cancer can be offered to elderly individuals at high risk of lung cancer. there is a 20% decrease in lung cancer specific mortality using low dose CT scanning in that select population that we mentioned earlier. So individuals with a 30-year history of smoking. And screening decisions, therefore, in this population should be based on the patient's life expectancy, their health cognition, and the risk of disease and their preferences. In, again, early this year, January, there was a study on cancer mortality and predictions for 2018 in selected Australasian countries. This study found that the predicted cancer mortality rates worldwide were going down, except among those countries studied, except in the Philippines. And this, again, study was reflective of worldwide smoking, non-smoking in those patients. Now, the question would be, why was mortality not decreasing in the Philippines? There are several hypotheses regarding that, one of which would be that the economic situation in the Philippines, maybe the ethnicity or the beliefs of many of the Filipinos that are preventing them from pursuing further management of their cancer and their view of cancer itself. So, well, the hypotheses have not been tested and might be a good area of research in these countries. Okay, so approximately 57% of patients in this study, this is a study on the prognosis, decision making, and age in correlation to age and comorbidities in patients with lung cancer. And the conclusion of this study as early as 10 years ago or so was that the age of the patient should not factor in to whether chemotherapy is an appropriate option because the treatment improves survival in both younger and older patients. In other words, there was no correlation to treatment response regarding age. So, how do we go about evaluating the older patients with cancer? It's a difficult path to tread. Despite remarkable advances during the last decade, lung cancer remains a leading cause of mortality worldwide, with non-small cell lung cancer being the dominant subtype. Approximately more than, and the patients are over 70 years old. Screening for those with comorbid illness, poor functional status, or short life expectancy may lead to an overdiagnosis and treatment of cancers that otherwise would not have caused symptoms during a patient's lifetime. There is a degree of fatalism that has been associated with the elderly failing to seek medical attention on a preventive basis, mainly on the now very superficial excuse that they are elderly. Okay? And screening may distract from discussions on issues with more evidence of benefit, such as, for example, reducing multiple drug use in these patients, or healthy behavior counseling, or fall prevention, again, in this population. So what can we offer our patients who have lung cancer and who are in the senior ages or the senior years? And admittedly, that's majority of these patients. Again, to review, in the United States, the life expectancy of an 80-year-old is mentioned at 9.1 years more. And for females, it's 9.7 years, and for males, it's 8.1. The median survival for elderly patients with untreated early-stage cancer is 14 months only. So if you will look at the years of that and the untreated early-stage lung cancer elderly patients, the numbers, these suggest that life limitations in the elderly group are purely cancer-related. So age-related differences should be immaterial in terms of discussion of age, and the treatment that is offered to the not so senior age group and the senior age group should not differ. And these include surgery, radiation therapy, chemotherapy, and now the exciting new field of cancer therapy. Lung cancer is usually treated with a combination of these interventions. Just an overview of what we offer lung cancer patients in general. If the stage is early, as we mentioned, surgery is a very viable option. We just have to evaluate now our patients, whether young or old, on their probability of surviving the intervention. For stage 2A and 2B cancer, surgery and adjuvant chemotherapy can be offered. For operable stage 3A, then offer the surgery, and if they are apprehensive or do not want to proceed, then perhaps a combination of systemic chemotherapy and radiation can be offered. Even for lung cancer or small cell lung cancer, the limited disease can benefit from radiation with chemotherapy, which is often used in these individuals. Targeted therapies for advanced stage non-small cell lung cancer are now preferred over platinum-based doublets. These previously, if you will look at stage 2A and 2B, and stage 3A, possibly platinum-based, which is cisplatin, was a mainstay of therapy. Right now, if these go advanced to 3D or 4, then targeted therapies are options in those patients whose tumors express certain genetic mutations. The patients have to be tested for the presence or absence of these genetic mutations, such as EGFR. In immunotherapy with anti-programmed death, one monoclonal antibody is approved for the second-line treatment of non-small cell lung cancer and is now a new therapeutic class of oncologic interventions available for these patients. So we mentioned surgery. Yes, surgery is possible in early stage lung cancer. They should not be denied to elderly patients just on the basis of their chronological age. Limited resections and omission of systematic mediastinal lymph adenectomy can be considered in the elderly on the basis of retrospective data. It is possible to offer them pneumonectomy, but this is not really a top of the line option, especially given the possibility of the existence of other comorbidities. So that might be a better option since it's associated with the lower incidence of post-op morbidity. For elderly patients who may or may not be operable, then localized radiotherapy could represent stereotactic. This is stereotactic ablative surgery or radiotherapy could represent an alternative with less adverse events. So there are possibilities for these individuals. And to reduce post-op morbidity with subsequent negative impact on quality of life. Okay, so looking at these patients, depending on the type of treatment that they receive, they can spend an average of 1 in 3 days interacting with the healthcare system, going back and forth to their doctors, going back and forth to the hospital. they will receive the care, but it might be at an expense that are not medical in nature, that are not directly medical in nature, such as the effort of going to and from the healthcare system. Patients with a higher number of medical conditions treated with surgery have the most treatment burden. Therefore, it would help for us as healthcare givers to consider reducing the number of their visits, scheduling them on the same days, and visits to the different interventions where rehabilitation physicians, their pulmonologists, their oncologists, if we could coordinate their schedule such that they only see their doctors coordinated on the same day, I'm sure they would appreciate it greatly. We could also reduce redundant tests, labs, and medications and improve, therefore, their quality of life. For locally advanced disease, then we can offer sequential or concurrent CMRT. This is combined modality systemic therapy, and as an option for these patients. Admittedly, we have to say that the studies involving these patients, as we mentioned, they are often excluded in clinical trials. The studies involving these patients are not voluminous, and there is very limited data available for octogenarians, and therefore it is difficult to make specific recommendations for these groups. Okay. So for these patients, we have to consider some biologic modifications related to age. Many of these patients often have a little bit, if not significant, derangement in their renal, liver, and gastrointestinal system. They have lean body mass that is diminished, therefore they are less tolerant of weight loss, which the condition can incur. There is less bone marrow reserve, so therefore some of the medications that can cause bone marrow suppression from chemotherapy have to be taken into consideration. They have comorbidities, as we said, and polymedication. And there are pharmacologic consequences considering the existence of some renal, liver, and gastrointestinal conditions. So, we need to assess who is going to benefit from surgery. And we need to define the functional status by standard preoperative assessment tools. These are the ECOG and the Karnofsky scores. This, however, might not be as reliable in the advanced stages, and newer variables have to be introduced to tailor the most adequate treatment strategy for each patient. Again, personalized treatment. How about therapies that can be introduced prior to the chemotherapy? Specifically, these are neoadjuvant therapies. Adjuvant therapies are those that you introduce after the chemotherapy. There is limited data in these individuals, and therefore, in fact, for adjuvant radiotherapy, the data is very sparse and no recommendation has been made for this particular intervention. As we mentioned, much of the cancer, unfortunately, is detected in the late stages. So prospective trials still support the use of carboplatin-based doublets in fit elderly patients whose systems can tolerate this intervention. For less fit patients, there are treatment options like gemcitabine, vinorelbine, and taxane that may be an option for you. These are single agent interventions. However, the overall survival compared to doublet is not really that robust, and very limited data always has been available for octogenarians. Okay, so for these individuals, how about immunotherapy? Then it's not exactly new, but it is. There are newer therapies introduced almost every year, if not more than one or two in a year. Very early stage non-small lung cancer, surgery is tolerated quite well. Alternatives of surgery like stereotactic body radiotherapy has been mentioned. However, and if age alone, though age alone is not a reason to forego treatment, it is possible that there might be other contraindications or even patient preferences themselves that limit the use of these chemotherapeutic interventions. The development of an immune checkpoint inhibitor has revolutionized treatment and really offers exciting fields in this patient. And older adults, as we mentioned, are underrepresented. Therefore, very strong recommendations for or against certain interventions are honestly not available at this time. And the efficacy of these agents may offer some degree of hope to those who are willing to try and to venture in that field. So looking at these patients, looking at what is preventing their consultation or their advancement in therapy, how can we tell whether or what can we promise them or really not promise them? What can we tell them about the vista regarding morbidity and mortality given their age in the field of lung cancer? We must be aware that there is a multidisciplinary approach that is offered that will evaluate the environment, the social support, their cognitive status. Since age alone should not dictate what treatments can or cannot be used for lung cancer, a comprehensive geriatric assessment is always recommended. This is a multidisciplinary diagnostic and treatment approach that identifies medical, psychosocial, and functional limitations of a frail older patient. And this should be in order to develop a coordinated plan to maximize overall health with aging. For these individuals, it is possible to reduce the underestimation of those who will benefit from from the intervention, and to not overestimate those who might suffer a great deal of more morbidity should they undergo the intervention. Age does not decrease the benefits of treatment, but treatments may not be well tolerated for some individuals. So what can we get from a geriatric assessment? We will be helped by the sense of functional age of the patient. We can identify patients at higher risk of functional decline, and in fact, we can provide valuable the geriatric assessment can provide valuable information regarding older patients in clinical trials. So as I said, a TGA can decrease over treatment of patients who are more vulnerable. It can improve under treatment of the fit older individuals. and it can help to uncover issues and circumstances of the patient's life that are routinely assessed just based on their ECHO or Karnofsky scores. Who will be subjected? There is, again, a geriatric aid or G8 health status screening tool to identify those individuals who can benefit from a CGA. And this takes into consideration the food intake. They are asked not only what they eat, but how they acquire what they eat, the degree of mobility that they are capable of, and in fact takes into consideration their drugs and their age. There are two tools that have been used to assess life expectancy and risk of morbidity for patients who are undergoing chemotherapy. One of these is the Cancer and Aging Research Group, or the CHARC chemotherapy toxicity tool. It takes into consideration several risk factors and classifies the patient into low risk, mid risk, or high risk of developing chemo-related toxicity. The other tool that is employed is the chemotherapy risk assessment scale for high age patients, or the CHARAC score. This score is often takes into consideration the psychological and status of the patient and divides risk into hematologic and non-hematologic tools. The tools, both the CHARAC and the CARD score, stratifies patients, and because of the feasibility, the ease of use, and the degree of prediction of chemotherapy risk, both scores are recommended with the CHARC tool more recommended for use. So given that, we have subjected these patients to some screening. They are elderly, granted. Let us not allow our biases regarding age to inhibit their ability to participate in studies or to show that they can be benefited by these studies. In fact, there was one interesting study that showed that older individuals with cancer want to get treated. It may be the biases of their caregivers and the advice that they are given that are preventing them from joining the clinical trials and affording them some degree of hope. In these few minutes, we have discussed that cancer is a disease of the aging, and as the senior population continues to grow, oncologists will treat an increasing number of senior patients. But age bias is a testimony to the social bias of medical practice. We should not be biased. Let us open our minds, screen more of these elderly patients so that they can benefit from the newer developments. The careful analysis of a physician's role in recommending treatment is necessary to contrast the implicit and explicit biases associated with age. Currently, a comprehensive geriatric assessment is the gold standard of practice when it comes to assessing risk and mortality. And this is the key to identifying deficits and disabilities in older patients with cancer. Therefore, we want to assure older patients with advanced cancer and their caregivers that we are one with them in the beliefs about curability. We are one with them in the goal to afford them a better quality of life. But we are still one with them in their decision of whether or not to accept the options that are offered to them. Our job is to provide them with a wide vista so that their decisions for their lives will be sound and to their preferences. So with that, I am again thanking for you for the opportunity to speak on this topic.
So thank you very much, Dr. Shasoko, for that comprehensive lecture on lung cancer in the elderly. So we would like to welcome our participants viewing on the UP Manila live stream from the YouTube Live and from the Facebook Live. We'd also like to thank our sponsors for today, Merck Sharp and Dome Philippines and Manila Doctors Hospital Cancer Institute for sponsoring today's webinar. So since this is a pre-recorded webinar, we'll be asking questions pre-prepared for this webinar session. So to start off, ma'am, the first question, since you've tackled that smoking is the main risk factor for the development of lung cancer, so in correlation to that, after smoking cessation, how long does it usually take to have a lesser probability of lung cancer?
Well, generally, that's because we expect to answer, we keep on saying, well, it can take years and years and decades. The arbitrary knowledge number is 15, and if after 15 the individual has not, of course, there are so many who have developed it more than 15 years. The sooner the cessation occurs, the better. And the younger the cessation occurs, the better. There are still individuals, however, who develop the cancer later. So the best intervention there is not to start.
So not to start early, or to stop.
To stop.
Okay.
Yes.
So how about, ma'am, for patients or for persons who have never smoked? Are secondhand smokers, for example, or patients, persons exposed to air pollution, are they at increased risk for lung cancer as well?
You know, the second and an interesting fact that I discovered, if ever was, we do have the second to cigarette smoking. So let's undoubtedly cigarette smoking causes it. Okay? The second one that causes it would be radon exposure. And in the United States, this has been found because radon is a side byproduct of uranium.
Yes,
it's in the soil. It creeps through the cement base of many of the structures. And for those who are exposed directly to soil or to their houses, that radon is still part of that. So it's still a carcinogenic agent. In the Philippines, biofuels for those who are non-smokers, or particularly the female non-smokers, are being studied not only in relation to COPD but also in the relation to the development of lung cancer. So yes, non-cancer still can get it. First, perhaps we should advocate we should spread the knowledge that even non-smokers can develop lung cancer.
So we should emphasize that non-smokers can develop lung cancer, and environmental exposures could predispose individuals to development of lung cancer. So, ma'am, you've touched on the use of low-dose CT scan for a particular set of population as a screening modality for lung cancer. So, for resource-limited communities like us, what is the most cost-effective screening tool? And in correlation to that, with a big jump in expenses from chest radiography and CT scan, what should push healthcare providers into further evaluation and opting patients to spend for low-dose CT scan?
First of all, again, as we mentioned, it's not useful to do screening with chest X-ray. So let's not go that direction for chest X-ray. I think one of the best would be to increase awareness, or to heighten or to sharpen the radar, which patients are candidates for the development, and so still the fallback, a good history and TE for the candidates for lung cancer, and then should should the suspicion be raised, then get the details that when did you stop, how old are you now, and then encourage really that the benefits of doing a low dose in that particular generation will pay off, or in that particular population will pay off. Given the options now, we have very nice, the patients these days in the Philippines.
Okay, ma'am. So you've touched on the utility of low-dose CT scan for a particular subset of population. How about for a resource-limited community like us? What is the most cost-effective screening tool? And then an adjunct question is, with a big jump in expenses from chest radiography and CT scan, what should push healthcare providers like us into further evaluation and opting patients to actually spend for low-dose CT scan?
Okay. So for the first question, I think an index of suspicion should be critical. As we mentioned, the low dose CT is not for everybody, but it will be more expensive, I would think, to screen patients with modalities that are not really that sensitive. That's the chest X-ray and sputum cytology. So doing this on a yearly basis is going to be more costly than beneficial. For those with how to encourage low dose CT scan, I would think that maybe the argument that it may, in the initial outlay, seem to be more expensive, but once the diagnosis is established, if the diagnosis is increased or established by low dose CT, there are provisions these days for therapy. And especially since this is early stage, the political structure, the government structure has it such that it will subsidize treatment for those who are detected early. So the benefits far outweigh I think, the costs of undergoing a low dose CT.
Okay, ma'am. So, in addition, you've already also mentioned in your presentation that the Philippines is actually the only nation in that subset of population that hasn't had a decrease in the number of survival after being diagnosed with lung cancer. So, are there data on the median survival rate and life expectancy, especially for Filipinos, since you've mentioned 8 to 9 years in average for the general population, for those diagnosed with early and those diagnosed with late-stage lung cancer?
I think those numbers are currently still being generated, and maybe a little underrepresented in the population that one are diagnosed and subsequently treated, because many of the patients once diagnosed either do not follow up anymore for one reason or another, or are discouraged because, again, of some belief in our society that once you have cancer, there is no hope. There is still hope. So I think the numbers for both these areas, generating hope, if you want to call it that, and generating the numbers that are really representative of the population to be treated, are still in the making. So I am not aware of any definite numbers.
Okay. So you've mentioned that some of the patients that won't follow up, one of the reasons is the financial burden. So you've touched on that lightly. So ma'am, can you give us a rough idea of the financial burden of treatment of early and then late stage of lung cancer in the Philippines with all the modalities that you've presented earlier?
For early stage, as I mentioned, surgery is still, and again, it depends on which institution you or the patient goes. In the Philippines, healthcare is out of pocket. Our healthcare is not subsidized, so we don't have the figures definitely are different for those who seek government hospital help and those who seek private hospital help. There are studies, however, in both types of institutions, both government and private, that may allow the enrollment of patients who have diagnosed. The critical point, I think, is that the patients should be diagnosed. Now, whether they are in the early stage or in the late stage, treatment options, or not treatment, medications are available. In the advanced stage, immunotherapy is available. And as I said, there are so many new studies now on immunotherapeutic agents, targeted therapy. And if one really will just I think for lung cancer, new drug was approved about 2 months ago. I had a patient who who took in that drug, and well, the costs were really great. However, the improvement in the quality of life can come the day after taking the immunotherapy, really marked reduction in the difficulty of breathing, and subsequently the hope that it generates in the patient. So I think that alone, the cost is immeasurable.
So emphasis on the early detection, early diagnosis. And then as you've mentioned, although most of the treatment options are out of pocket, there are institutions available that could assist the patient in getting this medication.
There are, in fact, like I think I was informed that there are survivors from a lung cancer advanced stage disease now into 14th year.
14th
Very,
year.
very remarkable.
Wow. Okay. So, ma'am, with regards to treatment, are there really particular comorbidities? Because you've mentioned that as we get older, the patients have decreased functional capacity, their ECOGs get lower. So are there particular comorbidities that may severely affect the disease progression and management of this patient?
I think the top three would be, four perhaps. Hematologic suppression from chemotherapeutic agents, gastrointestinal upsets again from the chemotherapeutic agents, and what will influence the response would be the presence. So those come after, if ever, the treatment is given. Before the treatment is given, they are usually assessed for their liver and renal functions to determine the ability of the body to take the chemotherapeutic regimen. The effects before the effects now are not as severe as before, where there was really marked. The patient had to stay home because of how they felt. But the patients now can go to the mall right after receiving their chemotherapeutic agents. So the side effects are not that severe with the newer agents.
Okay, so you've likely brushed on the topic. The next question, which is, what is the quality of life of older patients with lung cancer? And how will the side effects and complications of this chemotherapy affect the quality of life? I think the main question regarding this, ma'am, is immunosuppression, because they get the perception that once they start taking the medications, they aren't able to go out and perform their activities of daily living. So I think that's one of the hesitancy as well of those patients who intend to take these treatment modalities.
I agree that there may be a certain limitation, but I also feel that the quality of life is mainly a function of the patient's outlook. Okay. And the patient's outlook is also influenced by the information given by the healthcare givers, the support that the family gives. So prior to receiving the intervention, whether it be chemo, radio, surgery, or immunotherapy, I think the patients and the families have to be well prepared, well informed. They go into the therapeutic intervention knowing with full knowledge of what may happen, and actually for some prepared. And that's why I mentioned that some are really eager to resume their previous lifestyle. And if their previous lifestyle involves going to the shopping, sure, let them go shopping, rather than having them depressed and stay at home. So their outlook with regards to their treatment is a major factor in the reception or in the subsequent quality of life with their treatment.
So now you've mentioned a very important pearl, actually, that aside from all the medical aspects, the outlook and perspective not only of the patient, but of the family and